Yeah, it's still virtual here on a lot of our meetings. So, although some of the bigger meetings are going live, the fall clinical meeting in Las Vegas is going to be live this year, and it's coming up this coming week. So, but it is virtual too. I think there may be a track where residents can sign on to that. You guys might want to check that out. It's a great meeting, lots of good material and tons of good information. I think we'll get started. So we got 10 cases to go through this morning, but I think I've been an hour. I think kind of what we kind of allocated for this. So good biopsy here. Who wants to give this one a go?
I can take this one. So it looks like we have a punch biopsy, and we can, in our eyes, kind of drawn more to the sub-Q, where it looks like we may have an inflammatory process going on.
Good, excellent. Good. So right away you zoom in on the fat, and so obviously if you think it's inflammatory, what's the category?
So we're looking at some kind of panniculitis, and particularly a lobular panniculitis.
Good, excellent. So panniculitis is pretty logical when you think about it. You know, if you have your systematic approach, you say, was it lobular or septal mostly? And there can be overlap between those two, obviously, but that's the first thing you do. And then you ask whether you see vasculitis or not. And in order to really see vasculitis involving the larger blood vessels, are not really the large blood vessels like we see inside the body cavity, but they're larger than the capillaries and venules that we see in the top of the dermis and the papillodermis. Really all you need to see is inflammation in the wall of the blood vessels. You don't have to actually have fibrin in the in the wall of the blood vessel or thrombosis of the lumen, because it's not normal to get inflammatory cells migrating through those larger blood vessels. So that's probably the second question you ask, whether you think there's vasculitis or not. Then you ask what type of inflammation is there. Is it granulomatous, suppurative, whatever. So good, you're on the right track. So it's panniculitis, mostly lobular. Let's go to higher magnification. Any idea what kind of cells you might be looking at here?
Well, I think some lymphocytes, just kind of due to the smaller, darker blue nuclei. And then it looks a little bit more mixed. There's definitely some other cell types in there as well. So maybe some newts.
Yeah, exactly. Some neutrophils in here. Some of these are histiocytes. There's a histiocyte right there. So yeah, it's basically kind of a mixed infiltrate. It's got some neutrophils. It's got some little bit of granulomatous inflammation. It's not, like sarcoidal granulomatous inflammation. Then it's got this pretty large blood vessel here. And there's some inflammation in the wall of the blood vessel. And then there's this other blood vessel over here that does look like there's definitely some inflammation in it. So I think you could probably say, this isn't the world's best example of vasculitis. There's definitely some vascular inflammation associated with a lobular mixed panniculitis.
Yeah, so putting that together with the vasculitis with the lobular panniculitis leads me more towards like an erythema induratum, as opposed to others on the differential for a lobular panniculitis.
Good, excellent. That's exactly right. So what other items are on the differential diagnosis of a lobular panniculitis? You don't have to go through all of them, but what are a few others that when you first of all sort of low power, say lobular panniculitis, what kind of things instantly sort of pop into your mind that you want to start excluding?
You could think of like a lupus panniculitis, but you would expect to see some additional like perivascular inflammation higher up in the dermis. And then you could think like a pancreatic panniculitis. And those are kind of like the top ones, but again, the features don't, the subcutaneous lymphoma or subcutaneous like T-cell lymphoma, would be another one as well.
Yeah, good. Those exactly. Those are things you would look for. And there's the only one of those that or an infectious panniculitis. Those can be lobular, mostly panniculitis, but none of those really make a lot of sense here. Subcutaneous panniculitis, like T-cell lymphoma, sometimes when you look at the cells there, they almost look like neutrophils because they actually are lymphocytes, but they acquire the ability to phagocytose other lymphocytes and lymphocyte breakdown products. And you get these beanbag cells that sometimes kind of look like neutrophils, but they're really not. So that would be something you would always want to exclude as well. And then lupus panniculitis, get a lot of mummification of the fat with a lot of sclerosis and lymphoplasmacytic aggregates. That really wouldn't look like this. The only other panniculitis that sometimes can give you a neutrophil-rich lobular, mostly panniculitis, is alpha-1 antitrypsin deficiency panniculitis. When you get the stage where the patients have the bad sort of degeneration of their fat and they get systemic manifestations. If you ever biopsy one of those lesions, it'll show things sort of like this a little bit. So that's something else. But pancreatic panniculitis, you may get a little bit of inflammation there, but you get that classic sort of ghost cells with the calcification. So it didn't look like that either. But those are the major ones that you want to think about when you think of lobular panniculitis. And then if you see the vasculitis, and normally we just had a case just the other day of a beautiful case of erythema induratum or nodular vasculitis that had the obvious blood vessel that was thrombosed with fibrin. So this may be sort of downstream from the vascular injury here. It's kind of interesting because you would sort of a priori think, well, if there's vasculitis plus lobular panniculitis, you would expect to see a lot of fat degeneration and maybe some, necrosis because there's some ischemia. You usually don't get that. It usually looks kind of like this. The fat is actually still preserved. It's just got a lot of inflammation in there. So it's almost kind of a paradox about what you would think. So if it is erythema induratum or nodular vasculitis, is there anything else that you would want to do here on the patient now that you've made the diagnosis? Any underlying disease, for example, that you might want to exclude?
Tuberculosis.
Yeah, you have to worry about tuberculosis. And usually if you do a stain on this, it's almost always negative. And if you do PCR or anything like that, you usually don't find evidence of atypical mycobacterial infection or mycobacterial tuberculosis in the actual tissue. It's kind of a tissue reaction pattern. And we see this, the textbooks, all the classic teaching is it's associated with AFB or mycobacterial, MTB. But actually, we see this same pattern in similar in erythema nodosum leprosum. It doesn't look like erythema nodosum histologically, it looks more like this histologically. And in certain other infections that can sometimes be associated with panniculitis, it can give you this pattern. So even though classically in the old days, they're saying it's kind of a quote tuberculid related to tuberculosis, it's really a panniculitis reaction pattern that can be seen in a number of different infections. We've seen it in blasto and cocci and other things like that too. So just remember that it's not specific for the mycobacterial infections. It can be seen in other infections as well. Okay, so we're starting a little bit of a theme this morning. So this is, boy, this guy deserves a gold star for his biopsy here.
I'll take this one, Dr. Cockerell. This is Leah, one of the Baylor first years. So my eye is drawn, so this is a punch, but my eye is drawn to something in the deep subcutis. It's very basophilic.
Yeah, this might even be kind of a telescoping punch. In other words, this looks like, I'm not sure. I'm not sure if is that skin. Yeah, I guess it is. Okay, I was thinking maybe he did punch and he punched deeper, but it's actually just two halves of the same thing. You're exactly right. It's situated very deep again. So good.
So just based on the way these cells are looking, even though it does look rather nodular, it still looks kind of like a dense inflammation. So I'd probably be thinking more of like your inflammatory pathway primarily.
Good.
And then I guess the question now is what type of cells these are.
Yeah, what type of cells do you think they are?
So they're basophilic and they're kind of palisading, I see at the edges. So I think mostly I would think about like macrophages, especially
Yeah,
with that
absolutely.
necrobiosis in the center.
Yeah, if you look over here, you see a lot of these are pale, and then some of them are a little darker black cells. So you're right, there's lymphocytes and there are histiocytes here. And you said they're palisading, and that's exactly what's going on here. They're forming this little sort of fort, if you will, around this sort of central collection of material in the center, which is helpful in making the diagnosis. So basically, it's one of the palisaded granulomatous dermatitis entities that we have to think about. And so what are the three main palisaded granulomatous dermatitis that you have to sort of think about in dermatology?
I know rheumatoid nodule is the one that primarily jumps to my mind.
That's definitely one of the three. And what are the other two?
Maybe GA.
Yeah, GA. That's the most common palisaded granulomatous dermatitis that we see in dermatopathology. So you've already seen lots of GA, even though you've only been in your residency for 6 months or whatever.
And then NBL.
Yeah, NLD, necrobiosis lipoitica diabeticum, which is seen on the pretibial area of patients with diabetes most common. So those are the three most common that we see. Now, if we're going to try to distinguish between those, or among those, I guess I should say, what criteria do you use to tell the difference?
Well, I know that this one has that like necrobiosis in the center, and those palisading macrophages just make me think of the rheumatoid nodule, but I'm not sure if there are other criteria.
Well, there's a better way to do it than that. And I've never liked the term necrobiosis because it's always seems sort of like an oxymoron to me. It's like death, life, well, how can you be dead and alive at the same time? And I guess it's saying that it's live tissue that's dying. I don't know why they came up with that name. To me, I just like to talk about the morphology, and it looks like it's palisaded granulomatous dermatitis, like you said. And then you look in the center of the palisade, and you want to see what's in the center. And if it's pale and granular and bluish gray like this, it's mucin. If it's pink and homogeneous, it's basically fibrin. And if it's sort of thick kind of collagen bundles that are degenerating, well, then it's, obviously collagen bundles. So a few collagen bundles probably from the dermis here. I don't really see a lot of fibrin here, but I do see a lot of mucin. So when the other thing is used to be called years ago, I learned this from Dr. Al Kopf, who taught us at NYU many years ago, is that these were called the thesaurus moses, like thesaurus, like Roget's thesaurus, that nobody even knows what they are anymore because now we have Google spell check. But basically, it's basically the thesaurus is the Greek or Latin word that means treasure. And so basically, we want to think what's in the center of the treasure chest here. And if it's mucin, it's almost always going to be granulomedullary. If it's mostly fibrin, it's going to be rheumatoid nodule. And then usually the pattern of NLD is not really like this. So that really doesn't come into the differential diagnosis. What's the pattern of NLD? When we look at that histologically, does it look like a subcutaneous nodule like this?
No, it's like the layered cake.
Exactly. It's kind of a diffuse granulomatous pattern that involves the dermis, and you get plasma cells. It does look like it's basically granulomas that kind of alternating with collagen bundles that are degenerated from top to bottom and side to side. So it really doesn't ever give you the pattern. So that would really, even though that's in the classic differential diagnosis of palisaded granulomatous dermatitis, it doesn't give you a nodule like this. So here, really, the only two main things we would think about would be GA, subcutaneous GA, and then rheumatoid nodule. And the other name for subcutaneous granulomedullary is pseudo-rheumatoid nodule, because it looks like a rheumatoid nodule. Clinically, it's a subcutaneous nodule. And here you can see it really and truly is beneath the fat. And then it is can be seen over the joint areas. So years ago, you say, well, these look like rheumatoid nodules. They're not rheumatoid nodules. The patient has rheumatoid arthritis. So let's call it pseudorheumatoid. Well, now we know that it's basically granulomedullary. So that's what it's a nice example. And there's basically, well, you tell me, what are some other patterns of GA that we see in both histologically and clinically?
Like interstitial GA?
Good. Interstitial GA, which basically clinically can look like this sort of pink nondescript patch almost. And clinicians never think about that. So that's good. That's one pattern that we see. There's a couple other patterns though. There's just a classic old annular GA that we see. There's also perforating GA where you actually get transepidermal elimination of the granulomatous infiltrate. So that you can see. Widespread disseminated GA, GA that's precipitated by sun. So people, we call that actinic granuloma, but a lot of us today think that's probably just a variant of GA. So this is just one of the variants. This is subcutaneous form. The one thing I'll just mention, the teaching point here, is that you can actually sometimes get epithelioid sarcoma is one thing you have to remember in the differential diagnosis of palisaded granulomatous dermatitis. It's deep, and that doesn't give you mucus in the center of the palisade. It basically gives you tumor necrosis. And that actually will stain positively with cytokeratin and also with vimentin. So that's one other thing. And then rarely you can see the caseating granulomatous dermatitis because it gets a central caseation, kind of simulate a palisaded granuloma. That usually is mostly generated collagen, and that can be associated or caused by an infection. So you want to make sure that you're not missing an infection too. So those are just a couple of things to think about.
Thanks, Dr. Cockerell.
You're welcome. Okay, this is another, we got panniculitis galore this morning, right?
Yeah, so I'm Edgar. I'm one of the Baylor first years. I can take this one, Dr. Cockerell.
Good.
So like you said, so we're looking at a punch biopsy, and seems to be, most of the action seems to be down in the sub-Q. From this level, it looks really pretty dark, so I'm thinking more of an inflammatory process as well. Most of the inflammation seems to be in the septal section of the sub-Q. So there's more of a septal panniculitis. Most of the lobules look pretty uniform. Not a lot of inflammation within the lobules itself.
Yeah, and this is, so on a scale of 1 to 10 regarding this septum of the fat here, how thick would you say this is?
I think probably like a 8. It's pretty big.
Yeah, like maybe 100. It's
Yeah.
really, normally it's kind of like this. It's normally like a little teensy tiny strand, and here you can see it's massively expanded and markedly thickened. So yeah, that's a beautiful example of a septal panniculitis. Now, one of the things we talk about septal versus lobular. It's really septal mostly because you can see it does spill out into the lobules. But when you get septa that are involved like this, I mean, that's clearly, it's like, that's the pathology, so the lobules are getting involved secondarily. And then what kind of inflammation is in here?
So this level looks probably mixed because I'm seeing some darker cells. I am seeing some giant cells as well.
Yeah.
But I don't think anything necessarily predominates. Maybe some lymphocytes as well, because there's some cells that look black.
But you're correct. It's a mixed infiltrate, and it's actually got definitely the multinucleated giant cells here. It's got a granulomatous component to it. So basically it's a granulomatous septal, mostly panniculitis. And notice where these granulomas are kind of located, where this granulomatous inflammation is located. It's located right at the periphery of the septa and the lobule. And that actually has a name that was given to it many years ago. I don't know if you know that name at all. You might have heard it.
I'm not sure. Would it be more like a chronic EN or like
well, it's a Meischer's radial granuloma. I don't know if that's just sort of a trivia thing, but that pops up on board exams. They might put it down as a choice. Just remember at the back of your brain. But the most important thing is that it shows you this pattern that you're recognizing as a lobular, septal, mostly panniculitis, granulomatous inflammation with a mixed infiltrate too. There are actually a couple of eosinophils in here, which we see in this condition. So what's the diagnosis?
So, I mean, the most typical cause of septal, or the mostly common, is like a EN, erythema nodosum.
Yeah, this is a classic, beautiful, doesn't get better than this, erythema nodosum. So that's a beautiful example of it. And this is when you get it at a fully developed stage, when it's really, they've got those tender, dome-shaped nodules on the pretibial surface, and you take a good deep biopsy like this into the panniculus. This is what you expect to see. So this is a perfect example. Now, you can get erythema nodosum when you get it really early before you get the granulomatous inflammation, and that can be a little more challenging to diagnose. And if you get it late, when you get a lesion that's almost resolved, then you may just get a little residual inflammation here and the septor still thickened and make a little bit of sort of degenerated fat where it was present in the lobules out here. So they can be a little bit more challenging when you get a later lesion. So it's better to diagnose it when it's in a fully developed stage like this. And then you can, really make a definitive diagnosis of this. Now you mentioned chronic erythema nodosum. Tell me a little bit about that. Is there, so let's say you get this diagnosis back, erythema nodosum, you're going to say, oh, great, we'll give you some aspirin and we'll see you next year, or what are you going to do with your patient?
I guess histologically, maybe we'd see more like fibrosis, more granulomas formation. But I guess we probably wouldn't see them in a year, probably follow up closer, maybe like 3 months or a couple months.
Well, maybe for the erythema nodosum, but we've got the diagnosis of EN. We know it's really not a serious thing. We know it's going to gradually go away over the course of time. But what about to your patient, him or herself? I mean, are you going to just sort of blow it off and say, okay, you got E nodosum, adios? Or are you going to say, wait a minute, you have E nodosum, we need to make sure you don't have anything else going on that may be associated with erythema nodosum?
Well, definitely you'd want to like rule out like, things like sarcoidosis, maybe like undiagnosed tuberculosis. So you probably want to get some imaging, maybe like a chest x-ray or.
Yeah, and so that's the main thing. So the board might show you this because this is so classic. I mean, you picked it up, how long you've been in derm now, 6 months or less. So they're going to expect you to be able to diagnose this pretty quickly. And then they might ask you a so-called second order question. So you make this diagnosis, patient has this entity. What's your next step going to be with regard to the patient? So yeah, you want to make sure they don't have an underlying sarcoid, for example. You want to make sure they don't have an underlying infection of some sort. So again, the concept of reaction pattern. So a lot of times people's fat gets inflamed when there's other things going on. So just remember that it can be a sign of something else. Maybe they had a strep infection, something along those lines. So you want to just make sure that you work the patient up and you don't miss some underlying disease that may be associated with it after you make the diagnosis. This is a classic, beautiful example. Hope everybody that saw the slide had no trouble making the diagnosis because it just is, it's almost perfect. Okay. This was a little bit more challenging. So we don't have something that's just kind of screaming right off the page at us to the same way that the last one did, but that diagnosis is still available to be made here.
Hi, I can go. My name is Jamal. I'm one of the UT Houston first years.
Okay.
Yeah, I agreed. It definitely did not just jump off of the page. I know in some of the slides, it was, for me, it kind of looked to be most of them like an inflammatory process, a punch biopsy, inflammatory process, and mostly perivascular. I thought it was mostly in the superficial area.
Yeah, superficial perivascular dermatitis. I totally agree with you. So when we look at that, once we decide that and say, okay, what kind of inflammatory cells are in here? And you can probably tell mostly going to be lymphocytes, we would imagine. So we're going to higher magnification, and sure enough, they are. So it's pretty non-specific. So then we say, well, where else are we going to look to see where? Obviously, they didn't take this biopsy just for fun. They think that the patient's got some disease going on here. So we got to decide, well, where is the pathology here? It's not, certainly it's not in the fat this time, not much in the dermis this time. So where do we think the pathology might be this time?
Like, is it in like the epidermis or?
Yeah, it's in the epidermis. So is this a normal appearing epidermis to you?
No, it seems to be a bit acanthotic.
It is. It's acanthotic, which is basically means thickening. And anything else about the acanthotic epidermis?
It looks like within like the, I'm trying to look a little bit closer. Don't feel like I see a whole lot of stratum granulosum.
Okay, so yeah, there might be a focal diminution of the granular cell layer. I agree with that.
Yeah.
There's a little bit of psoriasis from hyperplasia, but it's not like psoriasis, is it? I mean, this isn't like psoriasis. I mean, those reedy ridges should be down here in a really classic lesion of psoriasis. Notice how they're kind of fat. They're almost like a bunch of heavy football players huddling together there. You know, they're almost cold. The reedy are coalesced. They're large. They're sort of blunted, and they're kind of fat. And that's a clue to this diagnosis. So it's abnormal psoriasiform hyperplasia, but it's not prominent psoriasiform hyperplasia. It's got these blunt, heavy, these large reedy ridges that are, you know, they sort of coalesce focally. And then what about the cornified layer? Sometimes the most important changes are up there.
Yeah, it looks like there's a little bit of there's parakeratosis kind of throughout.
Yeah. Any pattern to the parakeratosis? We got something like something over here that's kind of interesting.
Oh, yeah, it's almost looks like it sort of spares for the most part above the follicle, and then it kind of has like adjacent areas with the parakeratosis. I'm blanking on, I think a specific name for that.
What's this little thing here that I'm pointing out to you? And actually, it's also here too.
This isn't like a corner lamella, is it?
No, good idea, because that should show you some dyskeratosis down here, and it should be just pure parakeratosis above this. It's got parakeratosis and orthokeratosis kind of alternating. Over here, you've got it, you know, ortho, para, and it's sticking out like a little spine.
Like a follicular plugging?
Yeah, it's a follicular plug here. Good. And it's also got that alternating ortho and parakeratosis. We look over here, we see parakeratosis, kind of run our pointer over here, and then it's ortho and para again. And we go this way, it's ortho and para. So it's kind of alternating both vertically and horizontally. And you've got this irregular, sort of blunted psoriasiform hyperplasia of the epidermis. You've got the follicular plugging. You got a sparse perivascular infiltrative lymphocytes. Any ideas that calls to mind?
Maybe like a PRP.
Yeah, this is classic for Pityriasis rubra pilaris. So it's a beautiful example once again. And if they're going to show you something on the board examination of PRP, it's going to look like this. They're not going to show you an atypical PRP that's got some weird findings or something like that. They're going to show one that's just classic. And this has every feature. I mean, it's got every single thing you'd want to see. It's got the alternating ortho and para, vertically and horizontally. It's got the psoriasiform changes that we talked about, and it's actually also got the follicular plugging. So this is a beautiful example of Pityriasis rubra pilaris. So, you know, I think this is just such a good example. This is a good case where you want to sort of look at this and fix it in your mind and say, this is what it ought to look like. We see a lot of biopsies get submitted to us as rule out PRP that turn out to be psoriasis or atopic dermatitis or something else, because those are clinically in the differential diagnosis, or mycosis fungoides. But histologically, when you've got this pattern, it's really pretty classic. The only other thing that we sometimes see that can simulate PRP pretty closely is this so-called biologic associated psoriasiform dermatitis. So patients that have got psoriasis and they're taking usually a TNF alpha inhibitor, but they get some breakthrough psoriasiform lesions that just don't respond to therapy. And then you biopsy those, they'll kind of look a little like this. Some of those actually have a little more spongiosis, and they may actually have, they usually have the alternating ortho and parakeratosis or the follicular plugging, but they can give you that kind of blunted psoriasiform hyperplasia. It doesn't look like a classic psoriasis under the microscope. So good. So I mean, it ain't get much better than this. So if you want to sort of picture in your mind some things that the page in your encyclopedia now that's completed, put this one in there, put that erythema nodosum in there. You can put that case of erythema nodosum a little bit, although that should have probably had a little bit more vasculitis than we would expect it to see. Okay. Anybody want to give this one a go?
I can go. Good morning, Dr. Cockerell. This is Usman. I'm one of the Baylor first years.
Great.
So this looks like a punch biopsy, and it looks like an inflammatory process. My eyes are drawn to this in the kind of superficial dermis and kind of extending pretty deep as well, to this pretty large, well circumscribed, circular basophilic nodule. It kind of has the cells that occupy it kind of form this reticular pattern. I think from this power, it's kind of hard to see what type of cells comprise it.
You said basophilic cells, that's good. So clearly a lot of these are lymphocytes, but then there are these other cells in the background that you can just see, they're not as dark. So basically what I would want you to say is, well, if they look lighter and it's an inflammatory process, they may be histiocytes. And I'm not expecting you to say, they're definitely histiocytes at low magnification. We said they might be. So we're going to higher magnification. We're going to see if we can confirm that. And indeed, we can, right?
Mm-hmm. Yes.
Here we've got what are we pointing at over here?
It looks like a giant cell.
Yeah, giant cell, multinucleated giant cell. It doesn't have pale cytoplasm in it that we might expect to see in a, say, Teuton giant cell. So something like this, we've got a wreath of nuclei around it, maybe a foreign body giant cell, Langerhans giant cell, something like that. Okay. What's the pattern of the granulomatous inflammation itself here? I'm sort of forming these
the pattern. I would say it's like, you've got inflammatory cells surrounding kind of these granulomatous areas. Like it doesn't look like or are you referring to perhaps like caseating versus non-caseating, or is that?
Well, yeah, you can see it's definitely not.
Route?
You also can talk about like sarcoidal granulomatous inflammation or epithelioid granulomas. You see these kind of forming they're almost kind of forming these little sarcoidal areas. So if you took away all the lymphocytes and you just looked at those together without maybe the multinucleated, well, that might be sort of, you think about the possibility of sarcoidosis, maybe, because sarcoidosis has epithelioid granulomas that form your round nodular aggregations, usually with few lymphocytes. Here we got a lot of these multinucleated foreign body giant cells, and we've got all this lymphocytic infiltrate. So we wouldn't think of sarcoidosis itself, but it does show a sarcoidal pattern to some of these granulomas here, which is kind of interesting. And then what do we got here?
These, I would think these might be asteroid bodies, perhaps.
Well, notice it's kind of got a weird sort of almost greenish gray color to it. And there's a little cleft around it. There's another little small structure there. The asteroid bodies will usually give you, looks like a little linear kind of cleft-like morphology with maybe sometimes you'll see a little tiny bit of calcification in there. So this doesn't even look like it really belongs here. And there's another clue. If you see this, where there's a line in the tissue, that's obviously not in vivo, that's something induced that. That's where the microtome blade, when it cut across here, dragged something through the tissue. So there was something here that had a little bit of it may be going on here as well a little bit. There's something here that's got some tensile component to it that didn't get sectioned. It got torn through the skin. And that's actually a sign of maybe what that can help you. It's a clue to the diagnosis a little bit. If we had a polarizer and we polarize this stuff would look like crystals in the skin.
So would it be some kind of, it's a foreign body, I would think, and perhaps like a suture material?
It's probably not suture. This was maybe some kind of, I'm not sure what this was. It may have been some kind of an injury. Patients sometimes get in car wrecks and they get soil gets implanted in their skin and they develop these sarcoidal granulomatous reactions around that. And you can actually polarize, you can see the material in here. Sometimes patients get tattoos and the tattoo material, the ink has got some foreign material in there, especially prison tattoos. Those very commonly will give you a granulomatous foreign body reaction like this. So this is the thing that's interesting about this case is that the inflammation almost has a sarcoidal pattern, which you can see with things more commonly, say like with silica, glass gets implanted in somebody's skin, that tends to form a sarcoidal granulomatous reaction with usually some lymphocytes. It's not classically sarcoid, but it can give you a sarcoidal granulomatous dermatitis with usually more lymphocytes. So that kind of helps you to distinguish it from sarcoid. And then if you can obviously see the material with polarizable and polarizing it, or like this, where you can actually see it in the tissue, well, then you actually have the diagnosis. So there are some subtle differences between this and sarcoidosis itself. If you just had maybe an area, like this, you might say, oh, the differential diagnosis kind of includes sarcoid here, but usually you don't get the large giant cells, at least not this many, and you almost never get this many lymphocytes. So if you see this pattern, it's a round nodule that you described, which you can see in sarcoidosis also, but it's got this other inflammatory infiltrate. You should be thinking about a foreign body reaction and then maybe polarize it. So that's good. So you're exactly right. It was granulomatous inflammation, and that's kind of the way to work through that. Did everybody get that?
Thank you.
That's right. Hopefully. Do you guys recognize this as a foreign body type granuloma?
Yes, we did.
Yes.
Good. Okay, great. All right, let's go into the next one. Okay. A little different animal here.
Okay, I can do this one. I'm Juliana, by the way. Hi. Okay, so here we have, it's hard to tell if it's like a punch or a shave, but it looks like it's something, maybe it's a shave that like looped around itself. But it looks like it's papillomatous.
Good, excellent. So I think you're right. I think this was a shave biopsy here. And this thing was sitting above the surface of the skin, and it's got this papillomatous character that you just mentioned just then. Exactly.
And so looking at kind of like the papillomatous structures specifically, because I think that's what we're going for, you see kind of like what looks like more like basophilic cells rimming the papillae, and that kind of makes me think of something ductal.
So you think it's a neoplasm?
Yes.
Okay, good. Neoplastic. And would you favor benign or malignant here?
At this point, I think I would favor maybe something more benign.
Yeah, it's very small. It's very focal. So yeah, we would almost certainly favor a benign process here. And then you said it was ductal. So you're thinking of maybe an adnexal neoplasm. And when we think about adnexal structures in the skin, what kind of, what comes to mind? What are some of the things that can be adnexal benign neoplasms in dermatopathology?
Yeah, so especially with like the papillomatous structure, some things you can think of are like scalp, especially if it's on the scalp, like Syringocystadenoma papilliferum, or like
Good.
ACAP. That's typically like on the vulva.
Okay.
Um,
What is a Syringocystadenoma papilliferum? What's the differentiation of that?
as in like what, like apicrine, eccrine kind of?
Yeah. Which one of those is that?
So let's see if we can see any, like, because if it's apicrine, you can see like some decapitation, which it looks like we can, and they're releasing the contents. So that's awesome.
Good. Yeah. So Syringocystadenoma papilliferum is a benign adnexal neoplasm of apicrine differentiation. So yes, that's exactly right. And that's what this is. And hidradenomatous papilliferum, you're right, generally tends to be situated on the vulva. What else sort of helps you to distinguish between hidradenomatous papilliferum and Syringocystadenoma papilliferum?
Yeah, so for the Syringocystadenoma papilliferum, usually you see it like opening to the surface.
Yeah, do we see that here?
Yes, we do.
We do. We see it right here. Good. And then you're right, hidradenomatous papilliferum usually in the vulva. It doesn't have to be there every time, but yes, that's usually kind of a dermal-based cyst lesion that you look at it and it doesn't really have a connection to the epidermis. So this one would be more consistent with a Syringocystadenoma papilliferum, and it's papilliferous because it's got this verrucous epithelial hyperplasia associated with the apicrine papillomatous component. So that's fairly common. And here's another area on this side over here. is, so where's the most common setting where we see these lesions?
I know they can arrive, well, they typically on the scalp, and I know they can arrive from like nevus sebaceous.
Yeah, it's depending upon who you read, it's either the most common or the second most common adnexal neoplasm associated with a nevus sebaceous. The other things, they get these benign trichoblastomas that look like basal cell carcinomas, but they're really not. This one's a very common manifestation of it as well. So yeah, this is a classic example of that. So
Nice.
good. So again, these are kind of board 101. They very likely will show you this, or they'll show you some adnexal tumors to be able to diagnose. So just make sure you know the criteria for diagnosis. Understand that this is apocrine differentiation. It's a beautiful example of that right here. And that which is decapitation secretion, as you mentioned. There's one other entity that's in the differential diagnosis of this that's not on the scalp, and it's not a hidradenoma papillifera. Anybody know what that entity might be? On the breast, for example?
Oh, like intraductal papilloma.
Yeah, like a nipple adenoma or erosive adenomatosis of the nipple. That actually can look a lot like the Syringocystadenoma papillifera. It's a little bit different, but it's in the same general family. So if you want to think of it as sort of analogous to it in a way. And then, the breast tissue is really a gargantuan giant apocrine gland. And if you think about it, that's kind of where it really came from in the embryo. And so it makes good sense that it would make benign neoplasms that can look like apocrine neoplasms. So that's a nice example of Syringocystadenoma papillifera. Now let's do this one.
I can take this one. This is Anna. I'm a first year UTH resident, Dr. Cockerell.
Great.
And so there's a lot going on here. This could be a large punch that kind of fragmented, or even like an excision.
Yeah. I like that idea. Actually, there's one other technique that we sort of forget about, but enucleation. In other words, they may have tried to make an incision over this thing and hoping it was going to pop out, and it didn't pop out quite as easily as they thought. So they probably took their scissors and try to dissect it out and that sort of thing. So it kind of looks grungy, when we first look at it here.
The part that I focused most on was on the very top, and then the part that's to the right of it.
Okay.
Yeah. So the part on the left, I see a lot of hair follicles in the dermis. That makes me think we could be possibly like in the scalp.
Yeah, good, excellent, very good. And I think that's helpful. And again, we always talk about asking what part of the body something is from, and knowing this is from the scalp is helpful, because that's where this lesion almost always occurs.
Yeah. And then the part of the specimen to the right of that, I saw, it looks like this like proliferation of like squamous epithelium.
Yeah, so basically you're thinking neoplasm.
Yeah, so I put this in the neoplastic category.
Good. And you said squamous, so you're thinking then epithelial differentiation. And you said it looks kind of like squamous, a little bit like stratified squamous epithelium of the epidermis. That's good. Did you think it was benign or malignant?
It's hard to tell. I think what I think this is, I think usually it's benign, but there have been some cases where it's been invasive or malignant. And like here,
yeah, and actually some regular old pathologists struggle with this diagnosis. And, it's a little bit challenging here because we don't have the entire thing. We've got what looks like a partial removal of it. And so it makes it a little bit more difficult to apply the classic criteria of small symmetrical circumscribed. But some of these lesions actually can be pretty large and they're still benign. So in this case, you have to kind of look at ancillary features. So we say, well, let's take a look at the individual aggregations themselves and What else are we going to look for to see whether we think it's more likely to be benign versus malignant?
Yeah, the squamous epithelium has kind of like this like rolling, scrolling kind of like appearance. And then there was a different area where it looked like there was a few different like cysts going on.
Yeah, exactly. So this, obviously, if we talk about a cyst, it's got to be an epithelial line structure, and we've got that, I think, right here. And notice what kind of differentiation do you think this is exhibiting here? Now, obviously, there's squamous differentiation, but if we wanted to say, we don't think this is a squamous cell, right?
No.
No,
Yeah.
it's not squamous cell. So what part of the epithelium do you think we're recapitulating here when we look at this?
Um,
Kind of guess what I'm thinking, but
oh,
this actually is part of the follicle. So this has
Oh, I
what's
see.
called
Yeah.
trichilemmal differentiation here.
mhm.
Got that pink glassy central cornified material. It's got, this looks like the outer root sheath of the follicle right there. Looks like a
Mhm.
trichilemmal sheath. Here we've got an area where there's what's this purple dark stuff right over here?
Is that calcification?
Yes, calcification in it. So we're looking at individual aggregations, and there's one other thing that we don't really see here.
There's
So
no
what's missing?
granular layer.
Well, there's no granular cell layer. You're right about that. But what don't we see cytologically here?
There's no like keratin pearls like
Well, there may be some of those here, but we don't see any mitoses or atypical keratinocytes or anything that looks atypical, right?
Mhm.
So if this is a large lesion, if this was a squamous cell carcinoma, for example, wouldn't we expect to see some pretty atypical cells if something got this big by neoplasia, that was malignant? So the answer is yes. We don't see that here. So when you don't have the ability to really always apply architecture, you have to then use secondary features. So there's really no atypia, there's no mitoses. So this is almost certainly benign, even though it's large. So what's the diagnosis of this?
I was thinking this was a proliferating pilar cyst.
Yeah, that's correct. Proliferating trichilemmal tumor is the other name for that, which is actually not a bad name because it does look trichilemmal. And the other one is proliferating trichilemmal cyst, or proliferating, isthmus catagen cyst, whatever. But so this is a benign lesion. And sometimes people look at these and, oh my God, this is big, it's deep, it's got to be squamous cell, Well, it's not. It's not squamous cell. It's totally benign. And you can make the diagnosis of benign if you use those criteria that you sort of went through. And you'll notice the lack that there really are no atypical cells. There's no mitotic figures. So you just have to realize this is kind of a pseudo malignancy, that it can look malignant because it's deep and it can be large. These things can be like the size of a golf ball, sometimes. And the other name for these in the old days was WEN, W-E-N. There's another name for this tumor. So it's totally benign. And it's a good example of it. And did everybody think this was more likely benign than malignant? Hopefully. They rarely can undergo malignant degeneration. Now, they usually don't, but they rarely can. So you said that before, which is true. And the calcification, you don't have to have the calcification in these, but they often are calcified. So that's a nice example of that entity. And it's kind of interesting that it was so fragmented, but they often are fragmented because they're kind of deep to the skin, and they don't come out always like a little regular pilar cyst. Okay.
Okay. Hello, this is Brandy. I'm from UT.
Okay.
So here we have a punch biopsy. It looks inflammatory, I would say, possibly granulomatous.
Okay, good. Yeah, you can kind of see that at low power. There's some histiocytes in here. It's got some lymphocytes in here too, doesn't it?
Yeah, it's kind of scattered throughout.
Okay, so let's go to higher magnification. And you said maybe some granulomatous inflammation. What's the pattern of the inflammation here when you just kind of look at it the way that it's distributed in the dermis.
Well, I remember you saying like sarcoidal last time, but I don't think it looks similar to that.
No, it's different. But
Yeah.
if you just were to maybe draw a cartoon of this, for example, you'd say it's pretty nodular and it's pretty diffuse. In other words, involving the papillary dermis, the reticular dermis goes pretty much all the way to the base, kind of goes side to side, and these are little nodules here. So we'd call this kind of a nodular and diffuse dermatitis. And I think you're right. I think there are some histiocytes in here. There's clearly some lymphocytes. There's some overlying epidermal hyperplasia as well. So let's go to a little higher magnification. We're going to see what kind of cells are in here. And yeah, there's some histiocytes here for sure. There's plenty of lymphocytes in here. And then we look up here in the papillary dermis. I mean, basically shows the same kind of change here. Was there anything else that you noticed in this when you started looking at it?
Yeah, I think that there's pigment in there, like the black.
Yeah, there's pigment in here. Good. So we had an earlier case of a sarcoidal foreign body granulomatous reaction. Is this normal pigment here?
No, I think it's exogenous.
It is exogenous. Now, why is it exogenous? So you got this on, you look at the slide, you come up with your difference diagnosis in your mind. So this looks like some kind of pigment in here with all this inflammation in here. And then you look down at the 4 or 5 choices and the multiple choices you got to choose from. And they have hemosiderosis with secondary inflammation. They have post-inflammatory pigmentary alteration or regressed malignant melanoma. They might have argyria. They might have gold. So which, are you going to choose any of those? Or are you going to say, no, it really isn't any of those?
No, that wasn't really what I was thinking of.
Well, what were you thinking of?
I think it's a tattoo.
Okay, good. It is a tattoo. What kind of material is this, do you think?
Well, I think it's hard to say because I think a lot of the tattoos look black no matter what, like color or like contents they have in them.
Well, not really. So in other words, if you biopsy somebody that's got a red tattoo that says mom on it or something like that, does it look like this?
I'm really not sure, honestly.
Yeah, there's the color of the tattoo pigment. Actually, you can see it in the under this microscope as well. So if it's red, it looks red, and it's cinnabar is the chemical, the element that they use. It's called cinnabar that actually gives you that red color. If it's green, you biopsy that, it looks green under the microscope too. And then it can be blue. You see blue there, so you can see these various colors. This is more brown. Now, carbon is jet black. I mean, it is just absolutely transmits no light. It's just totally black. Notice that this has kind of got a brownish